Welcome to the PAHCOM and CMS Partnership ICD-10 Provider Perspective. This webinar is offered for free and is available to, was designed for all small practice managers, providers, anybody who's responsible for administrative tasks in a small practice, particularly ICD-10 transition, our favorite. Our speaker today is Dr. Joseph Nichols. Dr. Nichols is a board-certified orthopedic surgeon by training who has been in healthcare for over 35 years. For the past 15 years, he has focused on healthcare information technology, including work in product management, database design, quality metrics, and other healthcare data-related activities. And he spent 5 years as CEO of a Medicaid third-party administration company. Dr. Nichols currently co-chairs 3 sub-work groups for WEDI. That's W-E-D-I, the Work for Electronic Data Interchange. And he has given numerous national presentations for payers and providers related to ICD-10 over the past 2 years. He is also a certified ICD-10 coding trainer and received the WEDI Merit Award in 2009 and 2010. PAHCOM is very, very proud to be working with CMS and Dr. Joseph Nichols to offer you this information today. It is being recorded and will be available to you ongoing. We will send you a link to that information. And if you can look at the slide that's up right now, it also shows where to get your CEU certificate. If you have any questions, please do use the chat on the left, and we will address your questions in order, most likely at the end, toward the end of the session. All right, with that, I'd like to welcome Dr. Nichols to the floor. It's all you, sir.
Well, thank you, Karen. Well, it's a real pleasure to be talking to you. As Karen mentioned, I came from a background as a provider. I've been in healthcare IT for quite some period of time now, but I originally was in practice for about 15 years in a small 2-man group. So I understand how changes in the way we record data, record billing can have a big impact. And certainly this is a big change. I'm going to walk through and talk about what some of these changes are, and I'd like to put them into a little different perspective and hopefully address some of the questions and concerns that have been out there about this transition and kind of why we're going there and how we're going there and what it's going to mean to us in small practices. So what we're going to talk about today is that ICD-10 really is quite different than ICD-9. There's lots of questions about why are there so many codes? How is it going to affect my specialty in particular? Why is detailed documentation and coding really necessary? How will it impact my practice? What's the role of the physician and office practice manager in this transition? What do I need to do to prepare? And how will ICD-10 help me move into this new world of changing payment models that seems to be evolving as we speak? So first, ICD-10. What is it? Well, ICD-10, as many of you know, is part of the International Classification of Diseases that was adopted by World Health Organization way back in 1990. So we've been on ICD-9, which is also maintained by the World Health Organization for about 30 years now. But we've actually created ICD-10, and it's been in place for some time. Most other countries are on ICD-10. The international version of ICD-10 is about 12,500 codes, but in this country we've kind of supersized that a bit. We've added about 69,000, or enough codes to make it 69,000 codes. So that's a lot of new codes. That being said, there are reasons why there's so many codes, and the number of new concepts we're dealing with are actually not that much increased. We have been using ICD-10 in this country since 1999, mortality, but haven't been using it for normal care delivery for morbidity, and will be doing that as of October 1st, 2014. So as of that date, October 1st, 2014, the law says under HIPAA Administrative Simplification Act that all claims will have a ICD-10 code with dates of service on or before October 1st, 2014. So that means for some period of time there will be claims coming in that will have ICD-9 codes that will be submitted after October 1st, and they're perfectly valid if the date of service was before October 1st. But all claims with dates of service before October or after October 1st, 2014 must be ICD-10 or they're not to be accepted. There's also ICD-10 PCS, which fortunately won't have to worry about on the outpatient side, but involves the use of procedure codes for inpatient procedures done at the inpatient level. We're not going to spend a lot of time talking about those because they really will not impact small practices. If we look at what's happened with ICD-9 versus ICD-10, we have about 3 to 5 digits in ICD-9 today, depending on the nature of the code. And the general rule is that you should always report the most detailed code wherever there is more detail. In other words, if there's a code that starts with 3 characters and there's other codes that start with those same 3 characters, the 3 characters are just a category. They're not really a code until we get down. The same thing holds in ICD-10. You can have up to 7 codes. Now, not all codes are required all the time. Sometimes codes as small as 3 codes are perfectly valid. But the same rule applies. If a code has more detail to it, only the detailed codes are considered valid from coding guidelines. Today, we have only E and V codes as alpha characters for some codes. In ICD-10, we have many alpha numeric characters. There are no placeholder characters. In 9 today, there will be these things called placeholder characters as we go forward. Terminology and the index and tabular structure, the documentation we have is really pretty much the same as it was before. There have been some changes. There's a lot more information, certainly, and a lot more code, so there's a lot more to those tabular indexes and alphabetical indexes, but the structure is very much the same. Coding guidelines are somewhat similar. There have been some changes. The big change is the number of codes. The thing that's probably most important is ICD-10 allows us to record much more, in a much more detailed way, severity, risk, complications, comorbidities, other types of things that are going to be critically important in determining the level and severity of illness. Today we don't include laterality. In ICD-10 we will use laterality to determine left versus right. And then we have this thing called combination codes, which means we put a lot of information into a single code. We don't do that much today. In ICD-10, we combine a lot of information in codes, and we'll look at a couple of examples of that. So if we look at the patient, really isn't going to change over this period of time. It's the same patient. If the patient is in a motor vehicle accident and has an open fracture of the shaft of the femur, that same patient in October has exactly the same conditions, but the way we code that is very, very different. In ICD-9, we have a code that will capture the fact that it was an open fracture of the shaft or the long part of the femur, but in ICD-10, we capture the fact that it was displaced, that it was comminuted or in many pieces, that it involved the right femur, that it was an initial encounter, and at what type or classification of open fracture it is. In this case, a 3A, B, or C, which means it's a very severe open type fracture, which is much more at risk than a class 1, which is a relatively minimal type open fracture. The challenge we have is that particularly when we're dealing with musculoskeletal and with fractures, a number of codes have gone up rather dramatically. All codes for femur fractures today, 16. In ICD-10, there's 1,530 codes to pick from for these fractures. In terms of looking at some other examples, today if we see a patient in the emergency room with severe persistent asthma related to an acute exacerbation, we can capture the fact that the patient has an acute asthma. There are things in red here and that there's been an acute exacerbation, but we really can't capture today the degree of severity or the fact that this was persistent. In ICD-10, we can capture that with this code, which says severe persistent asthma with acute exacerbation. So we're able to capture more information that's relevant to the patient's care, relevant to the severity of the patient's condition than we could in ICD-9. And this becomes very important in terms of trying to determine levels of severity, risk, complexity, in terms of trying to do analysis so that we're comparing apples to apples when we're comparing data. There's certainly a great deal of difference in a patient with mild intermittent asthma than one with severe or persistent asthma, and it's important to be able to look at that data and tell that difference. Here's just one other example. A patient is admitted with a rupture of the cardiac wall without bleeding into the pericardium. patients within 4 weeks of a myocardial infarction. Today, all we can capture really reliably is the fact that this is a myocardial infarction and that there's been some sequelae, but we don't know exactly what that is. In ICD-10, we can capture specifically what was the sequelae, that there was rupture of the cardiac wall, that there was no bleeding into the lining of the heart, and that this was an acute myocardial infarction, which is defined specifically as occurring within 4 weeks. So a substantial difference in terms of how we look at these codes as being able to collect better information about what the nature of the patient's condition is. But again, the big push is there's too many codes. We have 69,000 codes. But if you really think about it, there's really lots of words in the dictionary, but that doesn't seem to trouble authors. We pick the things that make sense, that help us, that are meaningful. We ignore the rest. We also know that because of the way these codes are structured, we have a lot of codes related to the musculoskeletal system. 50% of all of the codes are related to the musculoskeletal system. 25% of all the ICD-10 codes are related just to fractures. And if we look at all the fractures, 62% of the fracture codes are exactly the same, except for telling the difference between right and left. So we see, because of a lot of repetition of information in the codes, the codes are repeating for every single fracture. We have to say whether it's right or left, or we have to say whether it's an initial encounter, subsequent encounter, or sequelae. So even though it's essentially otherwise the same code, we have a lot of repetition in there because we're trying to capture these other details within the same codes. We have about 1,800 codes for fracture of the radius today, but really if you look at the unique concepts that are being captured, there's only about 50 codes within those 1,800 codes. They just repeat over and over again. The other thing that we know is that traditionally only a very small percentage of the codes are being used by providers. If we look at how some of these types of concepts repeat in codes, it's kind of interesting, the fact that, you know, initial encounter, that concept is in 13,000 codes, subsequent encounter, 21,000 codes. So a lot of repeating concepts that occur over and over again means lots of codes. But the good news is that these are relatively consistent. We can expect to see these in a number of codes, and to some degree it makes understanding these codes and how they're patterned a bit easier. This is just a study that I did on about 3 years worth of data for one of the blues, about 1 million lives. And if we look at how the codes distribute, 5% of the codes accounted for over 70% of the charges. And if we look at 10% of the codes and kind of add that to the first 5%, well over 85% of the codes, 85% of the charges are accounted for by 10% of the codes. So again, we see a very high concentration of codes. Now this isn't necessarily good, because to some degree today we're using a lot of codes that really are very unspecified or not specific. They really don't let us understand the nature of the data that we're looking at. The other thing is that the number of codes is very different in different clinical areas. So for example, if we look at fractures, the most impacted, because we have a lot of repeating codes about the nature of fractures. Today we have about 747 codes. In ICD-10 there's almost 17,000 codes related to fractures. Poisoning and toxic effect also has increased dramatically. But if we look at some other areas like migraine, there's only 4 new codes that have been added. Bleeding disorders, 4 new codes. And in a number of areas, the number of codes actually goes down. Mood-related disorders, depression, bipolar disease, we have less codes, gone from 78 codes to 71. Hypertensive disease, we have almost half as many codes under hypertensive disease as we had under ICD-9. So in those areas where a lot of codes were present that didn't seem to add value, those were actually taken away. So in some areas, we'll see that the number of codes has gone down. And in certain specialties like behavioral health specialties, there really isn't a huge change in terms of how things are being coded today in ICD-9 and how they'll be coded in ICD-10. And ICD-10 codes are really pretty compatible with DSM-4 codes. So impact in terms of behavioral health, probably less than some areas, but it all depends on the nature of the specialty and what specific conditions that we're dealing with. Now, in some areas we've found that the code can capture not only the condition, but actually goes the next step and is able to capture more detailed variants of that condition where appropriate. So today we can capture the fact that a patient has Down syndrome, and ICD-10. We can also capture the fact that the patient has Down syndrome, but if we have additional information that describes the nature of the patient's Down syndrome, trisomy 21 with mosaicism, non-mosaicism, which really may help us understand the variances and expected conditions and cost and challenges for patients with Down syndrome, we have that ability now to distinguish those variants of Down syndrome so they don't all look the same from a data perspective. The bottom line is, though, that coding really is dependent on the source of the information. And this is really the critical part of coding today, is that we need to make sure that we capture the data in the first place. You can't code, or you can't even put in natural language processing or any of those other tools information that simply isn't there. Now, I certainly, recall, even though it may seem a long time ago, when I was in medical school, it was drilled into our head. To do a complete assessment, we needed to look at the patient's external records. We needed to capture a full history. We needed to do a complete exam and do an internal record review and study. And we're to capture all that information, but more importantly, all that information is meaningless if we don't document it. The fact that we think it's going to be in our head, it really isn't. And so it's important that all of that information is not only captured, but it's also documented. We also know that documentation today could certainly stand some improvement. Anyone who's looked at clinical documentation today, while you'll find a lot of providers, physicians, clinicians, others who document extremely well and capture all of the relevant information, you'll find some charts that really are pretty lacking, fairly limited, very shorthand. No, we're in a hurry, but this information is important. When I go to see my physician, I like to know that he's capturing all of the information that I believe is relevant or important to what I'm discussing. I would prefer not to have to repeat that to other providers or to the same provider when I see him next week. So clinical documentation is important. It's not about coding. It's not about ICD-10. It's really about good patient care. But that being said, if we do the right documentation, there's hardly anything in ICD-10 that we won't be able to address as long as we're capturing information that's critical to patient care. We also hear pushback saying, well, there's a bunch of dumb codes. You probably heard in the newspaper all these silly codes like hit by a spacecraft or suicide by paintball gun as kind of examples of silly codes. But the bottom line is those are actually ICD-9 codes. They've been around for a very long time. We have a lot of codes in there that may not make a lot of sense. That being said, if you work for NASA, maybe it's important to know whether a patient was injured by a spacecraft. Maybe they want that for their data. If you don't use the code. So you really don't need to use those codes unless there's a reason to, but they're out there, but they shouldn't really inhibit things. We should really do something that is meaningful to what we're evaluating from the patient perspective. We also hear, and I hear this all the time when I talk to physicians, ICD-10 won't help me take care of my patients. And at any point when Dr. Smith is seeing Mary Jones, it's hard to make the case that ICD-10 is going to help him take care of Mary Jones at that point in time. But we have to think beyond that. Healthcare crosses all these boundaries of times and providers. Mary Jones is going to come in many different times, and we're going to be watching that over a period of time. There's a number of people that are going to be looking at all the data about all the different Mary Joneses. All of this information is going to be traveling across different providers, and we want it to be accurate and consistent and standard. And really, ICD-9 and soon to be ICD-10 is the only national standard that we have that defines the patient's health state. It's the only thing that's truly interoperable across all health enterprises. So it really is critically important, and it's critically important to the clinician and to healthcare in general and to patients that this information is accurate as possible. There are some folks who said we should just wait for ICD-11. Well, the challenge with that is that ICD-9 was published back in 1978, so it's already 30 years old. ICD-10 has been around for 23 years now. We've adopted our version of ICD-10 back in 1995, almost 20 years ago, and we've been using ICD-10 in this country since 1999. The rule came out to implement this back in 2008, and here we are at 2013 still struggling with saying we don't have enough time to implement it. So it's hard to project that ICD-11, which hasn't even come out yet, that given that same timeline and doing the math, it would be 2039 before we could actually implement ICD-11. So as far as I'm concerned, I think ICD-11 really is not terribly doable. Even the AMA has looked at that and said, you know, this just isn't really going to work. The gap between 9 and 11 is huge, and we do need that incremental step. But more importantly, we can't go another 30 years with a code set that at that point in time will now be 60 years old. Healthcare has moved beyond that, and we need to have better data about healthcare. There are some who say these codes aren't relevant to my business. You don't pay on these codes. And while it's true that it's unlikely that you don't pay on these codes today, we do know that changes in reimbursement are going to occur on both what was done and why. And in some other countries like South Africa, they look at both the diagnosis code and the procedure code to make a determination on the level of payment. And we're seeing that model of looking at episodes, looking at a combination of what was done as why to determine levels of reimbursement and new payment models. So I do think we're going to see that evolving. In addition, the level of reimbursement may be directly related to whether it's paid or not if the patient does not fall under coverage based off of these diagnosis codes. Moving it into an accountable care environment, understanding the nature of these patients' conditions is going to be critically important in managing and taking on risk. And we do know that we're going to see more sophisticated weighting systems based off of these new models. One of the biggest complaints is that documentation is an unnecessary burden, and you know, I would have to take issue with that. I think that really documentation is about good patient care. The number and types of new concepts required for ICD-10 really are not foreign to clinicians. There's nothing in ICD-10 that we shouldn't understand, know, and document today. And usually when I talk to clinicians and challenge them on that, we can't find any particular concept that says, hey, that isn't important in the patient care. And if you document those things in general, and if they're documented reasonably consistent, getting to ICD-10 becomes a lot easier because we now have the information necessary to use the tools, coders, and other sorts of things to come to a correct and accurate code. In addition to that, documentation is important because of patients. Patients deserve to have accurate and complete documentation of their conditions. They believe that the information about their health care is important, and they want to make sure that it's documented because they may move on or they may have other problems in the future, and they want this information to be transferable and interoperable. In addition, if we look at other industries, we capture very accurate and complete information, and we've learned to expect that. You expect that your waitress in your restaurant is going to capture your information accurately and that your bill is going to be accurate and you're going to understand what it is. Or expect your plumber or contractor to be accurate about what the problem is, what they did. And if we look at that in other industries, we really have to be able to step up to that in order to be able to respond to good, accountable care moving forward. So let's take a look at what some of these concepts are. If we look at ICD-10, specifically around diabetes, for example, today we have in ICD-10 we have 276 codes. Today we have about 83 codes related to diabetes. And if we look under that, there's really 62 recurring unique concepts between ICD-9 and ICD-10. Now, if we look at the type of diabetes, the items in blue here, type 1 diabetes, type 2, poisoning by insulin, those are concepts that are both in ICD-9 and ICD-10. In other words, those codes report those types of concepts within those codes. Things like underlying condition, drug or chemical induced, pre-existing, gestational, those are concepts that are new to ICD-10. Now, they're not new to healthcare. Those are still conditions that we should be dealing with and things that are important about it, but our ability to capture those concepts and codes is new to ICD-10. For diabetes associated with pregnancy, we can now capture in the code whether it's the first trimester, second trimester, or third trimester. Again, the documentation is not new. The fact of the matter is that the code is now able to use that documentation. But if the documentation is not in the record, then you won't be able to code accurately. And so it's important, again, to have that documentation for good patient care, but also because you're not going to be able to code appropriately if you don't have that documentation. Things like neurologic complications, we want to be more specific. Is this a neuropathy? It is a mononeuropathy. Things like laboratory findings. Today we capture whether there was ketoacidosis or hyperosmolality in both ICD-9 and ICD-10, but in ICD-10 we can also now capture whether there was hypoglycemia or hyperglycemia, which we really couldn't capture in ICD-9 codes. Again, is this additional necessary documentation? No, we should be documenting that today. Renal complications. Ophthalmologic, some things haven't changed very much. Ophthalmologic conditions, all of those concepts in blue are concepts that we capture today in ICD-9 codes and will be able to also capture in ICD-10. We've gotten rid of one concept that's rather vague in ICD-9, background neuropathy. That's just simply not there anymore. Skin complications, we're now able to capture more specifically related to the diabetes within a single code. Things like joint complications, neuropathic arthropathies, or other types of arthropathies related to diabetes, we can now capture in the code as well. And again, just more examples: oral complications, diabetic control, what level of encounter, and if it involves the right foot or the left foot from a foot ulcer, we can capture that. We can capture if it's insulin-related toxicities, whether it was accidental assault, those types of things. So these concepts, where appropriate, and again, you wouldn't use these, capture all of these concepts or these codes, but where appropriate, are going to be important in terms of trying to capture in codes as accurately as possible. Now, traditionally, getting to the code has been difficult because codes have generally been considered, the ICD-9 codes, as sort of an administrative necessary evil, so to speak, something we put a check on the super bill and send in. But there hasn't been a huge focus on, is it the right code? Does it accurately represent what the patient's condition is? Does the service code accurately represent what we did? Because that's really kind of our responsibility in healthcare as we're billing, as we're charging patients and payers. We have to be accurate in terms of what we did and why. The super bill is going to be a struggle, particularly in certain specialties like musculoskeletal care, orthopedics. We've seen such an increase in the number of codes, it's simply not going to fit onto a super bill in order to get an accurate code related to something as straightforward as a fracture of the radius or wrist. So, why is it important? Well, it clearly supports proper payment, reduce denials. It assures accurate measures of quality and efficiency. It helps us with accountability and transparency. It captures the level of risk and severity. It's going to certainly help us get better business intelligence and clinical research. But the bottom line is that good documentation is good patient care. The impacts to ICD-10 are significant. We're having substantial changes in coding. There may be change in contracting. There will be changes in billing codes. Benefits and coverage determinations may change a bit. We're going to see compliance for reporting, accreditation. All of these things are going to have to be redefined wherever they reference conditions or diagnostic codes. Pay for performance, present on admission type of models, all are going to be changing. Audits are going to be changing because a lot of these use these codes. So business impacts are significant. We need to be prepared for them. The main issue is making sure that we are coding in this new environment. Here's just one example and something to be aware of as we start looking at some of these quality measures moving forward. An acute myocardial infarction, for example, in ICD-9 is measured as 8 weeks from initial onset. In ICD-10, it's measured as 4 weeks from initial onset. In ICD-9, we had a fifth character that told us whether this was an initial or a subsequent encounter. In ICD-10, there isn't anything that says whether it was initial or subsequent. In ICD-9, we were unable to tell the difference between a subsequent myocardial infarction, in other words, a myocardial infarction that occurred within 4 weeks of an initial myocardial infarction, which is really a very different condition. So in looking at how we're changing, the definitions are good, they've been well vetted out, but they're very different. And so as we start looking at quality measures and measuring performance over a period of time, we have to be well aware that many of the changes we're going to see on quality measures across this transition period may be related more to data than performance. So we have to be very careful in looking at the transition here when we're looking at quality measures to make sure that we're really measuring performance and be aware of those areas where most of the changes are due to facts of definitional changes or data or reporting changes. Another challenge we do have to be aware of is that there is a potential for cash flow impacts. We have some changes related to coding and getting people up to coding and productivity levels and doing the right codes. Some of the payers may have some challenges around payment because they're changing their rules, and there is a potential that some of those rules may not work exactly as they wanted. There may be some payment delays. In addition, there are some increased costs for implementing this. Changes in things we need to do around paperwork, education, some testing internally, all could mean some increased costs. So the bottom line is with a potential for decrease in revenue and some chances that we may have increased outflows, going to have some reserves to get through this transition. And this is true of any major transition that we see in the healthcare business. Every time there's a major transition, there's a high likelihood that you could see some cash flow changes and you need to be prepared for it. Back in October of 2011, CMS in their regular publication, Will You Be Ready?, added this bullet: establish a line of credit. We need to have some way to make sure that you have some insurance for cash flow issues should that occur during this transition period. We're also going to see a change, or hopefully see a change, in the relationship between the clinical, business, and coding side, because really all of those sides are partners in getting at the right data and the right information out to make sure that we're doing the right thing in capturing information. The role of the clinician is primarily documentation, to document as accurately as possible the nature of the patient condition and the services done to maintain or improve those conditions. The role of the coding professional is to ensure that coding is consistent with the documentation. The role of the business manager is to make sure that all the billing is accurately coded and supported by the documented facts, and that when audited, we'll stand up to an audit because we have the right codes and we have the right documentation to support that. Implementation is something that's sometimes difficult to get your arms around. How do you get started? If you can't hire big consulting groups to come in and solve all this for you, you need to think about how you're going to approach this. Some of it's fairly straightforward, but again, you have to think through some of these things. What are your short-term goals? What are your long-term visions? Are you going to be part of an ACO? Or are you going to be part of taking a risk? Are you going to be part of new payment methodologies going forward? Are you doing studies now that are going to be impacted by this? And you need to think about that. Where are the touch points within your organization? What are the potential downstream impacts? And how can you position in a very competitive environment to take advantage of their ability to predict risks and to manage the burden of illness of populations for which you may be at risk? Phases involve first just having some understanding of what this is and understanding what the impacts are and where the potential risks are in terms of moving through this transition. Analysis and planning, really prioritizing focuses to those areas that are critical. Where's the high dollar, the high volume, the common things that occur all the time, and not focusing on some of those other things that may not be as critical as initially, and really prioritizing that effort. Creating some specifications for how you're going to move from this way of documenting or this way of coding to the new way of documenting and the new way of coding. Looking at how you can use translation models to give you an idea of what types of codes in 10 might be similar to codes in 9 that you might be able to use. Again, you shouldn't use these crosswalks simply to go from one code to the next, because you should be documenting and coding in ICD-10 natively, in other words, finding the code and following the guidelines. But certainly some of these crosswalks and some of these other tools will help you get a ballpark of in terms of analyzing what types of codes you'll be dealing with. There's a number of different analytic models for doing this. There's a number of different tools out there, and there's a fair amount of work in terms of just evaluating to make sure these tools do what you want. And finally, leveraging ICD-10 moving forward. There are some potential advantages, there are some potential risks, but being aware of that and coming through this with not only surviving but thriving under this new environment is going to take some definite planning. For a very simple type of approach, and it is simply create a scenario. Take some things that you see today on a regular basis. If you see patients with strokes, if you see patients with epilepsy, if you see patients with congestive heart failure, and that's a very frequent type of thing, create a scenario, run it through your system, pretend you're a patient coming in, walk through and look at the documentation you have for those types of case studies. Look at how you would come up with the codes and actually essentially do a fire drill to walk through this. This is really called a reference implementation model. We've never had any experience with this before, and the only way we're really going to understand is take what we do today and create a scenario and then try and use the information we have to see how we're going to handle. Some hospitals have even said they're going to start coding in parallel for up to a year prior to implementation. In other words, everything that comes in, they're going to code in both 9 and 10, both for training purposes, as well as to see where the potential impacts and gaps are. Now again, not all providers have that level of sophistication, but you can discover a considerable amount by just taking a few very common scenarios and walking through and just trying to shine a light on the gaps in the areas of prioritization moving forward. It doesn't take a very sophisticated project management to do that. In some instances, it's really just being aware and essentially going through your system and seeing how it's going to handle this in the new environment for the things you see every day. In terms of moving forward, accurate and complete documentation coding provides us opportunities to do a much better transition into this whole new payment environment, value-based, accountable care, reimbursement environments. We've got a better way of representing severity and risk, levels of complexity. Hopefully we'll have better information to support automated processes and more rapid reimbursement once we get through the transition period. Opportunities to reduce audit risk, to get better intelligence to support population risk management, and hopefully a lot more accurate measures of quality and efficiency because we have a lot more granularity and detail around the nature of these codes. So again, we want to thank you for being part of this. We've got some information here that you can look at in terms of how to get information about this particular presentation. And we'd like to kind of open it up for questions right now. If there are questions, we'd like to take those on. So we have one question here that says, how does CMS feel the turnaround time will be on claims submitted when ICD-10 goes into effect? And I wish I had a good answer for that. I wish I had a good answer for all of the payers. I know that we've been around the country working with all the different state Medicaids and trying to help get them set up to work with this better, done a lot of presentations for payers and providers. And I don't really have a good simple answer to that other than to say the more you can test with those providers, the better. Most of the payers that I know have been spending a lot of time, effort, and money for a very long period of time preparing for this. But again, it's not anything we've ever been through before. I do think that walking through scenarios, creating some test claims, finding a provider who works with you is really the best way to discover where potential issues might be. And then there was a question about online access to ICD-10. CMS ICD-10 website has excellent resources out there. You can download all of the codes, all the details about the guidelines. Everything that's official is out there on ICD-10. And on the ICD-10 CMS website, lots of valuable information. There are, of course, a lot of proprietary vendors that offer tools. The usual people who are putting out your coding books today will be putting out the same coding books tomorrow under ICD-10. They're already out. The draft versions are out. There are a number of tools online that you can use. Organizations like AHIMA and AAPC and others have a lot of information out on their sites, and whether you're a member or not, or WEDI for the Work Group for Electronic Data Interchange, there's a lot of information available even for those people who are not members of those organizations, and there's lots and lots of online resources. So I think there's probably almost too much information out there. The key is finding the right stuff for you, and again, the CMS website with their ICD-10 information has the official information about the codes, alphabetical indexes, the files themselves, so I'd definitely take a look at that. Then there was a quick question about modifiers. Just to mention that modifiers really don't have anything to do with the diagnosis codes, so we're not going to be seeing modifiers related to that. So modifiers are essentially the same as they have been. CPT, HCPC codes, other codes that use modifiers, they're going to be continuing to get their same regular updates and uses as they always have. So this will not impact those things. There's another question that's a great question. Will EMR companies be prepared for the transition? Again, that's one of those where I wish there was a good straightforward answer. Some are very well prepared. Some are very poorly prepared. The bottom line is knowing the difference between the two. Because in general, if you ask your EMR vendor, will you be prepared for ICD-10, they will usually answer yes, but that doesn't necessarily help you because you really need to know not only will they be ready to hold a code, but how will your system work under ICD-10? How will it help you capture the information you need? Will it help prompt you for information that you need to get to the right code? How easy is it for you to get to that code? And the only real way to do that, again, is to do a reference implementation. Take some stuff you see today, work with your vendor to just have them show you how that particular case will be handled in ICD-10, do a walkthrough. That'll really help enlighten you more. But you need to communicate with your vendors on a regular basis. They're driven by their customers. They have to listen to their customers. But if their customers don't do anything, they assume there's nothing that they need to do. So talking to your vendors and really testing them in terms of taking stuff that you do today, ask them to demonstrate how that's going to happen in the new system is really going to be very important. Now, let's see. There was one quick question about getting more specific ICD-9 codes to help cross to ICD-10. And, you know, it probably would have been a good idea at some point in the past to start getting more specific ICD-9 codes. But right now, the ICD-9 codes are frozen. We're not going to see any more updates in the ICD-9 codes. As a matter of fact, after October 1st, 2014, it is no longer a standard. It will no longer be supported as a coding standard or as a diagnostic coding standard. So, yeah, it would have been nice if we had had more specificity in the 9 codes, but we don't. So we do have a bit of a difficulty in going through the transition because we're going from very different types of codes and we're kind of changing the details. So it does make it a bit more difficult. But nonetheless, once we get to ICD-10, we should have a lot more information about, and as we move forward, that hopefully will lay the groundwork as we migrate on to the next version of diagnostic codes. Let's see. The one question was, are the complete ICD-10 volumes available for purchase in October of 2013? There are draft ones out there. The good news is that because there is a code freeze, there will be very minimal change. The only changes will be for what's called emergency adjustments until October 2015. So they should be pretty stable out there. But you can also download all the code sets, all of the tabular indexes, all of the alphabetical indexes from the CMS website for free. Now, they don't have quite all of the coloring and organization, but they have virtually everything in there, including all the guidelines, to really get a good idea of what's going on with ICD-10. I personally have never gone out and bought an ICD-10 book. I've downloaded everything from the CMS website. I use it on a regular basis, so I think you can find a lot of good information out there. If you haven't already downloaded those, it's probably a good idea to do. We had this question, are all other carriers required to make the change to ICD-10? Well, in general, since this is a HIPAA requirement, it impacts all payers, providers, and clearinghouses who are covered entities. Now, there is a slight exception to that. For certain types of insurers, like industrial insurance or workers' comp, for things like casualty insurance, they technically do not fall under the HIPAA legislation. So technically, they do not have to use ICD-10. Now, that being said, most of them realize that they can't do business, which they have to do with other payers, because they will all be on ICD-10 and won't be supporting ICD-9. So most have decided. I know in our state of Washington, our workers' compensation organization has said, look, we're going to ICD-10 along with everyone else, as have a lot of other of the insurers that technically don't come under HIPAA. But there is a potential that there may be some insurers out there in those non-HIPAA covered entities, casualty insurance, industrial insurance, that may not quite make it or may not be there. I think they almost have to go there in order to be able to do business with other payers. But again, they're not technically under ICD-10. See if there's some other questions here. There was one question about exceptions, about will there be exceptions made? In other words, will there be a grace period? And the answer to that is really there is no grace period. As of October 1st, 2014, for dates of service on or before October 1st, it must be ICD-10. I'm sorry, it must on or after October 1st, it must be ICD-10. The reason for that is that the systems need to have a cutover date, and there's been a lot of study and analysis over this over the past several years, and it was determined that if that date is not reasonably crisp, it could cause all sorts of system issues, which could impact payment and a variety of other things and could cause a lot of chaos within the system. So it was decided some time ago that we needed to have a cutover date. Now, that being said, the rules initially came out back in 2008. So it's been out there for a long period of time, and we've had another year's extension. But as I'm sure you've all heard recently, the statement's been made very clear. The date's not moving, and there's no plan to move the date, and it will be a hard cutover date. There was this one question, are you confident that Medicare, Medicaid, and major insurers will be ready? And, you know, I would not be so bold as to say that because one is, what does ready mean? We do know that most of the payers, and particularly Medicare that's been at it for a long period of time, but Medicaid, and I've been to almost all the states now and done site visits with on behalf of Nobles and CMS, and they've come a very long way in moving towards getting ready, and they've been working at it some period of time. That being said, we've never been through this before. It is a big change, and I think it's likely that we could have some challenges during this period of time. I've never seen the healthcare industry go through any sort of a major change, whether it's DRGs or other type of payment methodologies, where we don't have this transition period where things get a little dicey. And that's why it's important to be prepared and important to make sure that you have enough cash reserves to be able to weather through this transition period. Any prediction yet another delay for ICD-10? You know, I've been watching this very closely, and I think everything that we've heard is that the date is really very firm at this point. And one of the big challenges we have, if we tried to delay, the last study of the delay showed that there was substantial cost to the industry of the delay. A lot of people have moved down the pathway. Their systems are being set up for a specific date. There's lots of plans in terms of all the things that need to be done, all the testing that needs to be done, and if the date moves, the cost is substantial across the industry. So I personally don't think we're going to see any chance of this date moving. Now, that being said, stuff happens, but I don't think it's going to happen. And all the signs we've said, everything that's been communicated, everything we're hearing from CMS and HHS is saying this date is really quite solid. Another question, how long do you think we need to have reserves? Again, I don't have a good solid answer for that. I don't know if anyone could predict that. I would think that you would probably be looking at 3 to 6 months at a minimum to make sure that you've got something to cover. Now, that 3 to 6 months not covering all of your revenue, but certainly looking at for having enough reserves to be able to cover a significant impact to cash flow during that period of time, whatever that might be. One other question we had here is about the super bill. I think that if we really look at the super bill, and you know, and this is just my own personal opinion, I've never thought the super bill was really a good idea. But that being said, it's a very efficient and effective way to kind of check things and get things done. But the bottom line, our requirements is that our codes represent as accurately as we possibly can, given the coding system, what the patient's condition was. And in view of that, we need to be able to select the right code. If we have a super bill, one page, we can't possibly get 17,000 musculoskeletal in an orthopedic practice. It's going to be very difficult. Other areas where there's a relatively minimal set of codes, certain aspects of behavioral health, other types of things, you know, there's really a relatively small set of codes where you really can get a number of codes that would be quite accurate in describing the patient's condition on some prompt, or whether that's a super bill or something else. So everyone's got to evaluate that for themselves. I think the general rule is that we should be coding to the detail, the best possible detail that we can, given the patient's condition. And many times the super bill just doesn't sort of fit the bill for that. So that's something you have to evaluate on your own. Okay, then we had a question here. When will I be able to send claims with ICD-10 and expect payment? Well, the answer is fairly straightforward on that. You don't send ICD-10 claims until October, for dates of service, October 1st, 2014, or after that. Right? So before that, ICD-10 is not valid. ICD-9 is still the valid code to be sent in. Now, you can send in claims with test data to if you can find a payer who will help look at that, and a lot of payers are looking at test data for ICD-10, but you cannot send in production claims with ICD-10 prior to October 1st. Then we've got a question about what is the purpose of ICD-11. ICD-11 is the next anticipated version of the International Classification of Diseases. Now, it's important to remember that, again, when ICD-10 came out almost 25 years ago, it took us a very long time to get to ICD-10. Again, because the way we use ICD in this country is often more complex than in other countries. So that means that it's probably going to be a while before we get to ICD-11. But basically, ICD-11 is just a new version. We see new versions of code sets come out all the time. We see new versions for DRGs. We see new versions for CPT and HCPCS. Those codes come out and updates come out on a regular basis. these major version changes, and the version change between 9 and 10 is very dramatic. The next version change between 10 and 11 is significant, but it's not nearly the change that we're seeing between 9 and 10. So it is just a version change. It won't be out for first review internationally until around 2015, and then traditionally it's taken us a number of years to come up with the CM, or our own particular version of it, and it's taken even longer than that. So I don't think we're going to see ICD-11 around in practice for quite some period of time. Another question we hear is, after October 2014, can you send older claims for dates of service prior to October 1st, 2014 in ICD-9? The answer is absolutely. As a matter of fact, that's what you should send in, because it's based off of date of service. If come November you're sending in a claim with a date of service back in September, it's ICD-9. So it's based off, again, that's an important thing to remember, it's based off of date of service. On or after October 1st, 2014, it's ICD-10. Dates of service on or before, it's ICD-9. And it's independent of when you send the claim in. It's date of service driven. Then we have one other question. It's kind of a tough question at this point, is will these codes work with the format of the current HCFA paper claim form? That's a bit of a challenge at this point, because those claim forms are currently being reviewed for updates to support ICD-10, but currently all we have is a draft of those new claim forms. In theory, again, depending on how the claim is filled out, I mean, you could put in a 10 code. The problem is the systems are not able to read those very well. So we really do need the new HCFA form that it supports ICD-10. It just isn't quite out yet. That being said, most of the time these should be electronic, as you well know, but we still have a lot of paper claims out there, and we do need to have a form that's going to do that. That is, I'm not exactly sure when that's coming out. Let's see. Another question, will the date of service rule apply if the patient is in the hospital in September and discharged in October? Now, again, the hospital side is a bit different. It's not based off of date of service, it's based off of date of discharge. So on the hospital side, if a patient is discharged after October 1st, it will be ICD-10 regardless of when they came into the hospital. So hospital is date of discharge, professional side, patient side, it's based off of date of service. Yeah, here's another interesting question. This gets a bit more complicated. I can't give you all the answer here briefly, but there is a question about what if you bill hospitals by the day and you don't know discharge date. Well, as you know, there's a lot of interim billing that occurs. A patient's admitted or in the hospital for a period of time, and there's interim bills sent out while the patient is in the hospital. The bottom line is when the patient is discharged, that is really the final diagnosis. The time of discharge is the official diagnosis for that patient's stay. And that is the claim at the date of discharge that drives which code is used. In the interim, during that period of time, that billing is simply interim billing, and you use the codes that are appropriate at that time. But again, every payer is approaching this slightly differently, unfortunately, so you have to talk to your payers and say, what do I do about these interim bills? How would you like to see this? All of them have to take in an ICD-10 based off of date of discharge, but you need to get clear with them how they're going to handle those interim billings. There is a reasonable way to do it. It's just you need to check with the payers to see exactly how they're doing it. Okay, another question about the hospital based on the date of discharge. Again, this is only for the hospital's claim. So the institutional or hospital claim, what traditionally was the UB claim, is the claim we're talking about. Any physician billing, anything that's billed for a hospital visit from the physician or that is not part of the institutional inpatient stay is still billed in the traditional way based off of date of service, not off of date of discharge. So it's really the inpatient hospital claim that is based off of date of discharge. Anything that's outpatient or done on a professional claim is done based off of place of service. And then there was another question, so we should hold the billing for the end of September 2013. Well, there are some discussions that as we get close to the discharge date, some strategies may be to not bill or to merge those claims so that we're not billing a lot of interim claims on the hospital side during that period of time. On the outpatient or professional side, I would certainly not hold claims. I would continue to bill them and get them out there. It's just if you have challenges around that interim billing where we're looking at an inpatient stay that's over multiple days, or if we're looking at other claims where we're billing for multiple different types of ongoing services, we need to break those up so that it's relatively clean during that period. But again, you have to talk to your payer because all the payers are handling this somewhat differently, and you need to get clear how they're handling that specifically. Okay. Well, I think we've gone through most of the questions. A lot of great questions out there. We know that there's a lot of concern about this, and this is a big challenge. And I certainly appreciate the opportunity to talk about one of my favorite topics. I know this is a big challenge, and again, having been in a two-man practice, I know that it's really a challenge for small practices. But that being said, I think it really is quite doable, and to some degree, smaller practices have a little bit more of an ability to pull things together in an environment so that hopefully it won't be as big of an impact as a lot of people are concerned about. Thank you very much.
Did you mention the event, Joe?
Oh, yes. Thanks for the reminder, Karen. Yeah, so we will be having another one of these events on July 17th, and the focus of that particular one will be all about clinical documentation. So in that event, we're going to be talking specifically about how do we deal with better documentation? What are some strategies in talking to clinicians and helping set up an environment where documentation becomes second nature, and why is it important? What are some examples of the types of documentation needed in different specific clinical areas or specialties? So hopefully that'll be helpful to you. We're going to, again, it's very focused on clinical documentation, which I think is a key underpinning. But thanks for that reminder, Karen.
Of course, we're all very much looking forward to it, and we're really, really grateful to your help, Dr. Nichols, and also to all the other folks that work very hard to make this possible. PAHCOM has a partnership with CMS to roll out ICD-10 training for small practice consumption because there is so much to it, and we want to make sure that everybody has every opportunity to be successful in the transition. And all these things, the better planning, the better prepared you are, the less painful it will be in the transition. Change always has a certain amount of pain to it, but if you're prepared, then it's going to be a whole lot better, and you'll be back to your revenue stream a whole lot faster. So we appreciate all of you participating in this, and we thank Dr. Joe Nichols from Health Data Consulting and our other friends over at Noblest. And you can see the ICD-10 questions at noblest.org. If you did not get your question answered, or if you've come up with one after the fact and you're like, oh, I got to ask this question, that's where you send it. ICD-10 questions at noblist.org. And of course, huge thank you to CMS for putting all of this together and making it possible for us to offer this education and training. This is part of a series. We are offering the training every month. As Dr. Nichols mentioned, the next one is July 17th, and we will be sending you a link to that webinar registration most likely tomorrow morning when we send the recording video link for this event. So thank you all very, very much, and we look forward to seeing you next month.